All right, good afternoon, everybody. Got a small, intimate crowd here. That's great. That'll make for a good discussion here soon. But as you can see, you're in the using a shared plan of care to help control the chaos workshop. So I'm sure you all know that's where you want to be. But if it's not, feel free to duck out now. But you're going to miss out on some fun, of course. Just to introduce myself, my name is Drew. I am a program coordinator at the Division of Child and Community Health within the University of Iowa. And just some background, the Division of Child and Community Health is the Title V agency for children and youth with special health care needs for the state of Iowa. And it also houses the child health specialty clinics, which is, I think, one of the key partners in putting on this conference today. So.
And I'm Martha Hanley. I'm a family member foundationally. I have a son who's 35 with a serious emotional disturbance. And I serve as a family representative on grants, and I've worked as a family navigator.
And so we really are, coming here to talk to you about how we have been working to improve care coordination across systems for children and youth with special health care needs. Because I think, as you all alluded to, when serving this type of population, there's different places for school, healthcare, different systems out there, and we are working on a tool and a process to hopefully bring together all the various care plans and provide a more holistic care for these kids. So just to give you an overview of kind of what we're going to cover in today's discussion, the first is kind of what is this idea of a shared plan of care, why is it important to have a shared plan of care, and how did child health specialty clinics in the pediatric integrated health home actually implement this tool and process of a shared plan of care, and then how can you all help us, think and spread this innovative approach? Because I hope this is a two-way conversation, because as I said, there's some great people in the room, and we're still learning about this process and this tool. So we are very eager to hear from you all too.
So we're talking about what our shared plan of care project is, and Drew explained that we're still piloting it. So we're really eager to learn your impressions and your feedback on the product itself. So we'll start with this care. It's called a care map. Has anybody ever seen this care map? Have you? Okay. So this shows up a lot in discussions about care planning, because it's the representation of one child and all of the systems in which that child moves. So the person who wrote this is Kristen Lind, and she was receiving services at Boston Children's Hospital for her son, who's medically complex, as you can see. And one of the residents there said, "So tell me what your life is like as the parent of a child with special healthcare diagnoses." So she went back to her kitchen table, she sat down, she said, "I can't put this into words, I have to put it into a picture." So she just started drawing. She used different colored markers for the various systems in which her son operated. And so, this is her support area. This is all the health dentists and all the specialists. This is all the developmental assessments her son was undergoing. And truly, I've forgotten what his diagnosis is, but he was pretty involved. This is school. And she put a door there because she felt like there was a lot of gatekeepers getting into the education system. And all of the specialists, she put the bus drivers on here, for instance. This is all the advocacy that she had become involved with as the result of sort of falling into this world. This is recreation, legal, because this was a child who was going to have this special health care need all his life. So what sort of planning did she need to do in order to prepare him for the rest of his life? She sat back and thought, wow, now I know why I'm not getting the laundry done. That was one kind of aha moment. The other one was recreation was pretty thin there. And, we know for all of our kids, friends are a big deal. And so she said, I need to do more to beef up recreation. This is a woman with a lot of energy. And so I think she developed some kind of an adaptive sports organization in Boston. But when this has become pretty famous now, because when she took it to Boston Children's and showed it to her providers, they said, wow, this is really impressive. We didn't realize you were trying to deal with so many systems. So we're just going to stop that. Oh, would you go to the next one? We're going to give you an opportunity to care map for yourself. We're not going to take too long doing this. I had never done this with my son, but I sat down with him last night and I said, so let's make a care map for you. And he's 35, so he doesn't have an IEP or a 504 or anything like that. But, we came up with a pretty complete care map, and I think our aha moment was, wow, you have a lot going on. You have a very rich life. And it was a great discussion to have about that. So we're going to give you an opportunity just to take about 5 minutes, and this can be done anyway. There's not a right or a wrong way to do it. But, put your child, and for those of you who are professionals, maybe you could do it for a child you serve, or, we're feeling as if this type of thinking can apply to all kinds of populations. So, for instance, when my mother was in a nursing home, I thought she could use some care mapping, and she could use a shared plan of care. So I invite you, to just use sort of a fictional person if one doesn't come to mind. But put your child in the middle, surrounded by the family. My son preferred to do something different, but that's fine. And then as I was talking with my son, I said, so let's think about all the areas in which you move. One of his categories was fun, and fun is an important piece. There's school, and here are possible categories. Folk services, housing, legal, juvenile justice. So just for some ideas, but I invite you just to take a look at your own, what your child's care map looks like. We did this with our Family Advisory Council, and we had one of the representatives there do it for 2 of her children, who are twins, and she said even that exercise was just stunning. So I'll be quiet now so you can think. We'll do this for about 5 minutes. Okay, can anybody tell me, anybody here have 2 providers on their list? Okay. How many care plans? 1, okay. Anybody have 3 providers? So I guess, let's start over. Only 2 providers in the care map.
And providers, not just it's school, it's all those different,
all those different people then.
Yeah.
Okay, so I'm going to say, does anybody have only 2 providers on there? 3, 4, 5, 6, more than 6. And how many care plans are you finding? 5 out of 6 care plans? 7, so you have a care plan for each provider? Do you have 7 providers? And that's a perfect segue to our next slide. So hang on to the care mapping. Do you mind hitting that? So has anybody ever seen this diagram called the system of care? So this represents a system of care. There's a family, because it's never just the child with special health care needs, right? There's always a family that's trying to navigate and negotiate all of the worlds that the child travels in. And this has several different representations. Here, you can see that all of those elements that are listed on your care map are sort of arranged in a neat wheel and surrounded by community-based supports. And we think, wouldn't it be great to move from Kristen Lynn's care map that is, pretty well organized but sort of disparate into something that looks like it works all together. So that's what we're going to talk about today. We're hoping to get to something that looks less chaotic than the care mapping, looks more like this.
Great. So to do that, one tool in trying to pull those systems together and those multiple providers is development of a shared plan of care. And I'm going to have actually one of our partners in Indiana, actually the Family Voices in Indiana, has a really quick 3-minute video about a quick overview of what is the shared plan of care I want to share with you.
Shared plan of care. A shared plan of care is an essential tool in any approach to care coordination. A shared plan of care is a document that a family and their child's care neighborhood can use to keep everyone working together as a child grows. A shared plan of care includes 2 main parts. First, a medical summary to familiarize providers with the child's needs. And second, negotiated actions or plans to reach goals. Children who have special health care needs often have many separate medical, educational, and developmental plans. These can include diagnosis-specific care plans created at hospital discharge, early intervention plans, therapy plans, home health plans, school plans, or emergency and safety plans, to name a few. Actually, I just named a lot of different services. The variety of plans and the number of providers, services, and systems this represents can be overwhelming and confusing. Care coordination can help. A shared plan of care provides a set of information and clear strategies to guide all efforts. A child's care coordination team creates and updates a shared plan of care, using all the information about a child to create one comprehensive, user-friendly document. A shared plan of care, or SPoC, cannot replace all other plans, but it can do a lot to ensure everyone is working from the same information. Members of the care neighborhood can use different plans to provide updated information to ensure that the SPoC is current. Keeping track of details about a child's treatments, medical records, and health histories, and sharing information about needs and goals is a challenge. A shared plan of care helps by offering an integrated medical summary with demographic information, current medical and care facts, provider and school names and contacts, and core child and family knowledge, including their personal preferences. The SPoC's negotiated actions section lays out personal and clinical goals and lists strategies for addressing and achieving these goals. It has timelines for making progress toward these goals and lists who is responsible for ensuring they're met. The impact of a shared plan of care is strongest when it's continuously updated and shared with all members of the care neighborhood. This might mean that the same document lives in a variety of places and formats. Shared plans of care should be a part of a child's electronic medical record in each healthcare system where they receive care. They should be a part of the records in their primary care medical home, and they should be a portable tool that families have with them both on paper and electronically. Care coordination and ongoing partnership between families, doctors, and all members of a child's care team are essential to meet the needs of each child and family. A shared plan of care provides essential communication across all members of a child's team. A shared plan of care needs to be continuously shared with a child's extended care team. A shared plan of care needs to be updated so that the medical summary is current and goals are highlighted and progress indicated. Thank you to Indiana's Care Coordination Champions for contributions to this effort. This video was made possible by grant number D70NC27544 from the Health Resources and Services Administration, an operating division of the U.S. Department of Health and Human Services.
All right, do we have any Star Trek fans in the room? But yeah. How great is SPoC, right? And I bet as you were listening to that, you probably thought of a couple different, care plans or, plans that are, you have interacted with either, for a client you served or your own child, and as she kind of described some specific examples. But as the woman kind of overviewed, the shared plan of care is that concise yet comprehensive, it's integrated and user-friendly compilation of child and family-specific information. It really does, the purpose is to guide care and facilitate coordination among the child's medical provider and their community providers. And it's especially appropriate for kids with complex health needs. So we're not up here saying every child in the state of Iowa needs to have a shared plan of care, but it really is, based off of the research, most important for those with the medical complexities. As she also kind of mentioned, so it's got that basic outline of that demographic information, the picture of that care neighborhood. So you all started your care neighborhood here today, and then description of the child, the family strengths, the providers that are serving that child, and then the goals that go along with that care plan. So I'm going to skip this because it's a very overwhelming slide, and I do have specific bolded words here that we were going to go over, but essentially it does have, and we've kind of covered a lot of these underlying principles of a shared plan of care. But so this is the kind of a diagram to talk about how, so there's the tool, but there's the process, right? So the tool is only as effective as its implementation. So it starts off by, strengths-based, talking about the needs and strengths of the patient and family, having those discussions with the family about what are those things that you want to work on most. It goes on to building those essential partnerships for those people in that care neighborhood for that specific child. Setting those personal and clinical goals, and really emphasizing those tenets of shared decision making, and then it goes to the creation of the plan, developing that medical summary, establishing those negotiated actions, and this really happens in a family team meeting setting. And we'll go into a lot more detail in these things, but this is just a quick overview. And then the implementation. So following up with the actions that have been agreed upon for that child's care neighborhood, and making sure that people are staying on task as they move forward, and always evaluating and updating as you go. So for us, we adopted that kind of diagram and made it into this specific process where you have your pre-meeting steps, your team meeting, and your post-meeting, really. So your pre-meeting, there's a lot of work that goes along with this. So you're reaching out to the parents first and foremost, asking about their interest in and goals that they want to highlight, speaking to medical providers, other providers in the community, and then scheduling that face-to-face meeting with school, family, and medical. And as we learn, you may not get the PCP to come to this team meeting, but at least you're reaching out and getting those goals from the PCP ahead of time, and putting that into that shared plan of care. And then populating it for each child as they come due. The team meeting's held. The post-meeting steps are, following up with that completion, sharing that shared plan of care, and then, more tasks around making sure that that plan's moving forward. So we have some screenshots of a specific shared plan of care. This is the tool that we use within our specific piloting project, which we'll talk about a little bit more. But as you can see, right at the top, some demographic information, basic information around date of birth, age, insurance plans, and then what we put a placeholder. We're still figuring out this picture part, but what we've learned from conversations with providers is that, especially in the hospital setting, is that there's interns that see the child, but the child's PCP may not actually, or was it the other way around? The intern may not know exactly what the child looks like. What was it? The
intern tends to know. So this was a discovery when we worked in our initial pilot with the UI General Pediatrics Clinic. Because it's a teaching hospital, the residents will come in, typically see the families. So the attending physician said, we need to have a picture because we don't know these kids. So which was a real discovery for us. So but providers who have a lot of kids on their caseload, no matter where they are, would appreciate a picture. So this is a placeholder for a picture of the child, and then a picture of the child's family, child within his family. So we're working on that when we have, and Drew will talk about an electronic platform we have. So
yeah, and then a little bit farther down is kind of an introduction to the family. So what does the family want you to know about them? Getting those out there first and foremost. Kind of what are their hopes and dreams? What are they wanting from their providers? And then really that primary family concern for that child or youth. And then kind of documenting, are there other plans out there? Are there school-based plans like IEPs or 504s? And then a basic family information contact for that child's parent or the guardian or whoever it may be. So and so this is the medical summary portion, going over what diagnoses, what medications they're currently on, what current interventions and treatments, and this treatment approaches tried that were unsuccessful was another discovery we found from our Family Advisory Council, is that they just wish that the providers that worked with those kids, that they would know what's been tried in the past, so they don't keep trying something that they know is not effective for their child. So a quick medical summary, and then the family structure, who's living in that family's or that child's home, what's their relationship to the child, and any important information that if you need to know a sibling that also has a diagnosis similar to the child, or what other information about that family do you want to share with the provider that you're handing the shared plan of care off to. The family care team, so that care neighborhood, so building out those contacts that you all worked on your own sheets. So who's the care coordinator, who's the primary care physician. And I do want to kind of emphasize that this is all within the context that there is a care coordinator involved, and that is a luxury for a lot of people, and that's something that we need to figure out what this looks like in a place where that's not a thing that a family has access to, because you do have to have a quarterback. You have to have someone that's filling this plan out, talking with providers, gathering goals. So we totally recognize that that's not available across the state, but this is how we're piloting at first. But so other providers are further down on the plan. So this is the goals section. So we have our general goals. So this is the section you would fill out, the care coordinator would fill out as they reach out to the child, to the family. as they reach out to the primary care, the school, and any other subspecialist or provider that works with that child. And then so this section wouldn't be filled out. The prioritized goals wouldn't be filled out until the family care family team meeting, because it's it's one thing to gather those goals, but then you have to have that discussion with everyone in the room about so how are we overlapping? How are your goals impacting my goals? And then let's now discuss how they all work together and prioritize those goals. And so in the way that we're piloting this, that the family goal really has to be one of these prioritized goals, to make sure that that's not lost. As a family member may get into a room with a lot of providers, they may feel overwhelmed, a lot of terminology being thrown around, but as the care coordinator is implementing the shared plan of care, they need to ensure that that family voice is as part of the prioritized goals process. Yeah.
So in terms of a care coordinator, where is it exactly that this is occurring, that you are developing this? Because I think maybe I lost that in the presentation.
You haven't lost it. We haven't gone over it yet. So that's great. And then maybe that's good feedback, because maybe I'll make sure I share that earlier on. But I'm trying to just give an overview of the tool itself, and then I think we'll get to that for sure. So if you have any questions after I get to that, please let me know. And then as part of the shared plan of care is this idea that there are other additional plans, is there emergency plans and any other plan that you can kind of fold into this shared plan of care. And then once this family team meeting happens, we want to make sure that there is documentation of agreement. So we have signatures from those participating in these discussions, and then ensuring that we're documenting it's being shared with those providers that have been part of the discussion, and of course the family.
So why have a shared plan of care? I think, a lot of what you said at the beginning about how many providers you all are working with, how the providers work in silos, that they don't talk, which can be a real safety concern, that providers don't always know what the history is. They don't think of talking to the family, even though the family is the expert on this child. Because I'm a family representative on the grant, I'm really excited about the shared plan of care, because I see this as an opportunity to shift to family-driven care. We talk a lot about family-centered care, and family-driven care is a step further, where the family really has the primary decision-making role, and we recognize that not all families are ready for that. So families need coaching by the professionals, and they need just some awareness building about how vital their voice is to the process. So, and a lot of this thinking has come out of the mental health world, I believe. I got this information from the Federation of Families for Children's Mental Health, that the family-driven care is so important. Of course, we know that children should receive care in home and community-based settings, but they should also receive treatment. This was from a Child's Bill of Rights. Receive treatment within a coordinated system of care where all agencies delivering services work together to support recovery and optimize treatment outcomes, or the child and family just aren't going to move ahead. Next slide. Thank you. And there has been some data collected on how important it is to have care be family-driven. And so here's some of the research that's occurred, that outcomes improve when family and youth are active participants in their own treatment. That's intuitive. If a family is involved in the care and agrees, has a voice at meetings, agrees to the plan of care, then they're going to be greater participants in the process. And that extends to youth. When the youth and families are given leadership roles, we're going to have better clinical outcomes. And so across systems, family involvement is critical. And I think most systems are discovering that. So they're spending a lot more energy in bringing families into the discussion. And it's because families are the experts. This is a quote. There isn't a lot of research on care planning, but there is sort of a key document that we'll reference later. But what this parent said was, I kept thinking they weren't going to listen to me. Okay, screaming isn't working. What can I do to have them listen? That's gone. The care plan sort of levels out the playing field. We're both talking the same language. I may not have medical training, but I have this piece of paper. It gives me a level of comfort. It gives me a level of security. I would say it also gives a level of safety, too. Next slide. Most of our thinking about this comes from a document that was written in May 2014. So this is a relatively new idea, the shared plan of care. It was a paper produced by the Lucille Packard Foundation for Children's Health, which is out of California. And in that they said the purpose of shared care planning is to improve care, reduce fragmentation, to guide a multidisciplinary team process, enable the child, family, and their care neighborhood to communicate, collaborate, and operate from the same page over time. What we've discovered is that because of that collaboration, because of the need to reach out to partners to collect goals, because of the opportunity to collaborate at a face-to-face meeting, the relationships are being built among the siloed systems. And so care improves simply because folks are talking. And then it delivers oversight using developed timelines and by ensuring responsibility and accountability for results. And the family and youth get assignments, and they are accountable as well, and they're given timelines. So they're considered as equal parts of the team. And there's been sort of a flurry of discussion in the literature about shared plan of care. Sometimes it's called comprehensive care plans, but typically, I think when it first came out, and we've had this grant to work on this, we're in year 3 of the grant, it's going to end in August. I think there was discussion about what are we going to call this, as we call it a shared plan of care, but pretty much there are 16 states working on this. I think everybody's calling it a SPoC.
Yeah.
This is the shared plan of care. But there is we're seeing this concept about the importance of collaborating in care planning occur in the literature. This is a document that originated in Canada just about care plans in general. And, it said in order to be a comprehensive care plan, it has to be dynamic. So we keep saying that the care plan has to be living. We know many care plans that are sort of locked in dusty file cabinets, but this has to be a living document. We have to have shared values. The content has to be shared. It's all predicated on the ability to share information and to build relationships among the care team. And it should improve the quality of care. It should improve safety, because when a family walks into an emergency room, they have a copy of their shared plan of care with all of their care team contact information. They can say, this is my crisis plan, this is my safety plan, here's my pharmacy, this is my preferred hospital, and this is what my care team has agreed on. We're hoping it's going to improve caregiver stress, and improve patient and family-centered care, and make care more efficient and timely. What one parent who was cited in this article said was, they always told me that I was a member of the team, but I didn't believe it until they put my goals on the care plan. And this comes out of the McAllister article, Safety, it's optimal management. We make progress against goals. We share certain goals. So even though one provider might have 6 goals, another provider might have 2 goals, we don't take those providers' 6 goals for the negotiated goals just because there's a preponderance of goals. We say, what are sort of the overlapping themes that are emerging? So it sounds like your concerns are the same as my concerns. Let's work on that together. And so we get those down. And it doesn't matter, probably 3 or 4 goals. I heard Jeannie McAllister speak, and she said, everybody wrote down there can be only 4 goals. She said, there don't have to be only 4 goals, but there does need to be one family goal. We're hoping that it reduces duplication because people are collaborating in goals. We hope that that it saves money, which is, always something we have to think about, but that family members will be able to work more, that the child goes more to school, and that there's reduced burden on the family.
The grant that I helped coordinate at the division, like we mentioned, it's kind of funding a lot of this activity, at least for us. And it's got a big component of it is evaluation. So we are trying to ensure that are we seeing these outcomes or we're not. So I think this is going to be important when we're talking to healthcare plans in the community. Does this actually reduce ED visits? Does it have those tangible cost savings components? And then talking with family, does this reduce caregiver stress? And then looking at the system are we really improving collaboration across systems and increasing the number of providers interactions. So that is a big component of as we think about rolling this tool out. So We kind of talked about kind of what is a shared plan of care, so hopefully you kind of got a general idea of what is a shared plan of care. We talked about the why, based off of the research, based off of all those outcomes that we're hoping to get. So now I want to get to your question about the how have we done it. So we've initially piloted this process and this tool within the Child Health Specialty Clinic's Pediatric Integrated Health Home, which covers northeast Iowa in 5 sites, and these are the other the orange dots are the 15 regional centers that are part of the Child Health Specialty Clinics, and then 5 of them house the Pediatric Integrated Health Home. And Martha, do you want to just a quick overview of the Pediatric Integrated Health Home? I mean, we know we have some people that are experts, but just so everyone else knows.
The Pediatric Integrated Health Program serves children on Medicaid with serious motion disturbances up to the age of 18. So, and the Pediatric Integrated Health Program and the adult version, the Integrated Health Program, is present in every county in the state.
Thanks, Martha. So we've started this off in about 3 phases. Our first phase was back in April and June of 2016, where we made it very small, where we focused on only 11 children that were served by that Pediatric Integrated Health Home as part of the Child Health Specialty Clinics. They were stratified as severe, so it got that medical complexity component that's important for the appropriateness of the shared plan of care, and then receiving care at 1 pediatric integrated practice and enrolled in at 1 school district. So before we enrolled this out, we had conversations with the Iowa City Community School District about this project, and we reached out to some of the pediatric practices within the University of Iowa about this project. So really building those relationships as we roll out this plan out. And so we took what we learned from that initial pilot, rolled rolled some changes into the tool, into the process, and then rolled it out to about 80 children that are currently enrolled in the Child Health Specialty Clinics, still within the Pediatric Integrated Health Home, but are receiving services from the Children's Mental Health Waiver. And so, again, Martha, give us an overview of the Children's Mental Health Waiver.
These are the kids who have applied, are eligible and have received services through the waiver, the Children's Mental Health Waiver. So for those of you in the system, this is what we're using as the ISP, the Individualized Service Plan. So we developed the shared plan of care to meet the requirements of the Individualized Service Plan for the waiver, but also meets the requirements of the shared plan of care.
So yeah, and so then in the beginning of this year, we have started to roll this out broader than that specific, population within the PIH program to all children within the Pediatric Integrated Health Home stratified at that severe. So still that complexity level that we're looking to roll this out with. So that's kind of the area, and then within kind of the teams that are part of these Pediatric Integrated Health Home. Just to give you an overview, so within Child Health Specialty Clinics, we have a social worker who is the primary care coordinator for the child that's being served, and they are also most all of them. They all have a nurse and a family navigator
and a family peer support specialist. They're called, yeah. On the team.
So as you can tell, we're primarily testing this in a behavioral health setting. We do have, as I kind of mentioned, the lead care coordinator is a social worker. And then as part of the team, the nurse assembles the medical summary and is a liaison with the primary care. And then we're exploring pilots that look outside of the behavioral health world to look at those that don't have a social worker, so a different type of care coordinator, because the care coordinator is the general term. So the disciplines that actually play that role could look differently. So we're looking about how do other disciplines play that role within the shared plan of care. We're looking at those settings without that heavy, clinical, nurse practitioner or that sort of component as part of the team, and then those with more physical health diagnoses. So looking at how a shared plan of care works for that type of child. So as of right now, we've completed 74 shared plans of care. As you can, this is over that phase period that I've kind of alluded to here. It's very much a discovery process. As you roll out one at one, it changes based on the child, it changes based on the providers you're engaging, it changes based on the setting you're doing this in. And through all those, we're trying to learn the appropriateness and really build that evidence base to say, based off of our experience, this works for this type of child in this type of setting And there's some great key things that we're learning about. This has been important for those children in transition that are transitioning from the pediatric world into adult care. So this is a great tool to use as an intervention to help think about care planning for that I guess youth. It's been key in what was the most recent one? Well, I guess it's I think there's just instances where there's been maybe when there's been a crisis, or the child has been discharged, or some event that triggers a need to have this sort of team meeting approach. So there's some discoveries there that we're learning as we roll this out. And when you first hear shared plan of care, that can be easily confused with just another care plan. But we really are trying to make sure we're true to the fidelity of the model, that where we're looking at how is this different from just a care plan that a provider may create. How is it? Are we making sure the goals are being collected? Is it being shared? Is it the development of those negotiated actions? Is how making sure that this is a different thing rather than just the typical care plan, because that's going to inform how we draw conclusions about the benefits of this type of intervention. So this is just a tool that we are using to make sure that we're truly being staying true to the model. And then, as Martha kind of alluded to, we are putting this shared plan of care electronically. So we are engaging with a partner called ACT.MD. It is a cloud-based, HIPAA-compliant care coordination platform. So we're really excited about this because, paper's great, but as you print it off your printer or you write it out, it's immediately out of date. So how do we keep this electronic where it can be easily updated and it is a living document and it gets shared easily? I mean, to fax and email that it gets lost and puts in a binder somewhere and it gets put away. But if you have an opportunity to access this through your computer or your smartphone, then it's a better likelihood that you're going to be interacting with this and sharing with this. So, say the example of a family member, there's a ER visit. They have it on the app. They actually have an app associated with this platform that they can pull up their plan on and show that to that emergency room physician and say, this is who works with my child. This is the things I want you to know. These are the medications. It's just it's an easy way to share that information to those in that crisis situation. So yes, that is, we've made sure to ensure that we had some time to have some dialogue with you all. So like I said, oh great. So we have a first volunteer here. So.
While I'm walking over there, one thing that I'd like to mention is that you told a mental health and well-being work group that was established by the legislature a couple of years ago. They've established some learning labs, so looking for some innovative ways to address the challenges of families with kids with serious emotional disturbances, and this is one of the items that is being studied. So, Tessa.
So my question is, this is piloted through University of Iowa. Is this available to be implemented in other communities?
Yeah, no, that's a great question. So this tool is, as you said, being piloted as part of a specific grant within the Division of Child Community at the University of Iowa. So we're learning from that, but it has been worked into our Title V strategic plan, which is as I mentioned, the division is the Title V agency for children with special health care needs. So it's got that more broader reach, or thinking about how we not only serve those children being served by child health specialty clinics, but how are we better serving all kids with special health care needs across the state of Iowa. So as part of that plan for the state, it has been worked into nearly every priority we have about thinking about how we roll this out to other populations. So it's not, I think it's an incremental phase for this. I mean, it's not, so I think we're being cautious in saying this is best for this specific population we're trying to learn as we go. So yeah,
But the next phase, and because there's a work group within that strategic plan that's charged with the spread of the shared plan of care. And so one of the things we're going to be working on is to engage care coordinators and other systems just to have a discussion about this. Is this a good idea? What changes would you make? So that we're not set and we get feedback from other systems.
But as a parent, where can we get this?
Yeah.
Because right now you have it all at your location.
Yeah.
So I'm going to be really honest. Not everybody goes to U of I for their care.
No, of course.
So I feel like it's a good document. Is it something that you guys are willing to share? What resource can we have as a parent, as a coordinator? You know, we don't have a social worker. A lot of times we, the parent, are the social worker.
Yeah. Yeah. And
And it's
ahead.
interesting because one of the members of our Family Advisory Council took her care map to her legislator on the Hill and said, look how complex my child is. I have private insurance. And what do I need to do to get a care coordinator? Because I'm my child's care coordinator. And it happened that her legislator said, I'm going to get my friend, the lobbyist from Wellmark, over here, and we're going to talk about this. So I think, you know, a lot of our hope is to just get a discussion of the need out there, too, because parents are great advocates. Catherine, did you want to add something?
I think, if I'm understanding your question right, you're asking, you know, we don't go to University of Iowa hospitals and clinics for care, so are we going to get a shared plan of care? Is that kind of what you're wondering?
I'm asking, how do we go about it? Like, in the private insurance world, you hit the nail on the head. In the private insurance world, you fight for every single service. There's nobody standing next to you to help you. And I feel like, yes, that falls on the parent. So I want to know how we do that.
Sorry. And you know, right now this is something, you know, that we're doing in those 7 counties that you showed in Northeast Iowa. The 12 counties in Northeast Iowa through Medicaid. So those kids are getting, yeah, and those are kids on Medicaid. Yeah, so we're at the start of this process. You know, we do want to be able to make it more available to everyone across the state, regardless of, you know, what hospital or what physician people go to. So this is just a starting point of whether this design looks good. Does this seem like it's something that would be, you know, would be helpful for lots of families?
And I'd say, I mean, I don't think there's no proprietary information about this. I mean, this is about developing a tool that can be spread across the state. So, I don't know where everyone else stands in the organization, but I'd love to connect with you and say, you know, this is the template. Let me send it to you. If you feel like you want to implement for one of your children, we'd love to, you know, continue a conversation with you and learn about your experience with the tool. Because if this is something that gets you excited and thinks it's, you know, a way for you to improve the care coordination for your children, you know, definitely. I'll have our emails up here at the end, so let us know and I can send you it.
I have a question. Sometimes we've been dealing with or struggle a little with some providers because providers, they have their own goals and not really focusing on the family. So since this is like family driven, we will be adding other providers' goals, but at the same time, who really will be determining which are the prioritized goals. Because sometimes we have DHS involved, we have like some other juvenile court system involved. So who really is the person that will choose all that?
Yeah, and please add to this, Martha. But I mean, to me, it speaks to the need for that skilled facilitator of that care coordinator to really to be able to navigate differing agendas and differing goals and ensuring the family and the child in the center of those goals. So I think it takes that person to be there to help facilitate that sort of conversation. But yeah.
And that's why we've developed this to operate at a family team meeting, which wasn't occurring in all of the states, but we've received guidance that is the sort of the ideal setting for the development of these goals, so everybody has a voice. We want those family goals captured before the meeting, though, so the family is not intimidated at the meeting, and then the facilitator is the care coordinator is the one responsible for making sure that the family goal ends up on the prioritized goals. Does that answer your question? Okay. Is it Patty?
I guess my question is that the specialty children's clinic is doing this pilot up in my area where I'm from, Northern Iowa. And we also have the mental health center that does the integrated health home for children under the mental health waiver.
The case manager said.
Yeah, but they have, combination, but you've got one doing one and one doing the other, but we still find some children falling through the cracks. And it's not easy to get them into either one of the clinics to start out with. I mean, that's I guess where do someone like myself as a social worker or case manager or care coordinator, whoever, directs that family to those resources that we have A and B, but they don't qualify for either one. Or there's I'm not going to say a waiting list, but, we'll see them in 2 months, but we'll first do an intake, and 2 months later we'll come back and, so.
What kind of diagnoses are you talking about?
Anybody with a mental health issue or a behavioral, I mean, we've seen a lot more, we're seeing an increase in mental health issues in children are behavioral. And it's really, how do we know it's mental health or it's just behavioral, and where do we go from there? So it's kind of hard to, and to coordinate it all.
Yeah.
Because you got agency all trying to figure it out.
Yeah.
Right.
Yeah.
So access is a big concern of our program, and so one of the ways we're getting at that is to develop sort of a robust telehealth network, so that for kids who aren't able to get into providers, they can get a telehealth appointment. So you're looking for places for your own toolkit to be able to refer families and have sort of intermediate resources to give them while they're waiting.
Exactly, and that's the wait part. And if you're looking at mental health waiver, you've got a waiting list. Yeah, and then if you've got a person that needs to get in to see someone, well, there's such a backlog of what 2-3 weeks later, but they need it like tomorrow, type thing. It's just a hard.
It is, and I think that was the design behind the integrated health program, that at least there'd be a place to land where they'd get that family support, the social work support, and the medical support. So has that been successful in your area to refer them to the PIH? And maybe we could have a discussion about this afterward. Let's do that. So we capture these ideas about the shared plan of care. Any other thoughts about the SPoC?
Well, I think that I've got a child that doesn't really fit this. He's not on the CMH waiver. His needs are different, but the need for an integrated plan is still the same, regardless of whether or not the physician comes to the table or whatever. We almost need this template, like, here, take this and adapt it as a family, or adapt it for a family who's in a different situation than one of these pediatric facilities or in a facility or another care. So it's the same approach, but it's almost a completely different pilot program that you're working on. And I don't know if there's plans for something like that or not.
Yeah, and please don't, this isn't us saying that this is only specific to the CMH waiver population or even specific to behavioral health. The idea is that we're just learning from that population right now. So this is hopefully a tool and a process that can go across, different diagnoses. So yes, and we'll have, let me just put my email up here.
Yeah, thank you. Well, just sometimes it's just like probably everybody can agree with the goals and family needs, but sometimes it's more like a funding thing. When insurance are not really willing to approve certain service, it's just like a little hard to get in there. So how we can really approach that?
So, and that's the care coordinator's job to say, the family might want this, but it's not going to be funded. So that's all part of the discussion that occurs either before the meeting or at the family team meeting. Rebecca.
With your plan that you have, do you incorporate when you're doing the prioritization of the goals, does the family have the voice to say, this is what I want for my child? And when you're educating the family to speak up so that they know the language, because it's very difficult if they don't know the medical language, if they don't know the IEP language, they're very intimidated by that.
For sure.
And so they don't speak up, they don't know what to say, they don't know the questions to ask. Are you encouraging them to, because it's very difficult. The care coordinator also drives the bus. And so it's very hard for the family to know what to say, how to say it, and
Yeah,
what to do, and
for
how
sure.
to speak up for their child.
That's a great, and if you want to just touch on it
And,
lightly.
you know, we have wonderful social workers working for us. They are wonderful social workers, but I think by requiring them to capture the family goal in the family's own word, and we're also going to require that it be captured before, particularly a waiver meeting, because there really is waiver speak that happens. And if the family really wants those services, they're going to say, I don't care. Whatever they say is fine. I just want to get these waiver services going. So, but to say, what is really happening in my home, because we know that that can change everything. You know, I remember I did a SPoC last spring, and there was a youth who was a straight A student, first generation English speaker in her family. And she wasn't even on the school's radar screen. I reached out to the school and I said, we want to do a SPoC on this child because she's tiered pretty high in our pediatric integrated health program because she'd been hospitalized twice for suicidal ideation. They said, you're kidding. She's a straight A student. We discovered at the family team meeting, we said, what is your goal? She says, I wish my parents wouldn't fight so much. And we discovered, oh, there's lots of discord in this home. So we need to, that was one of the goals to, and the parents were there, and the parents agreed to counseling. But
So
that wouldn't have come up with typical care planning, I think. You're much more experienced than we.
So, and,
Well, the family knows. The family knows their own
Yeah.
child,
yeah.
They do.
and they need to know.
We need to.
No, so, and I think we're actually, yeah.
But they need to know, I mean, accepting them where they are in their home, their culture, their language, as opposed to provider speak.
Yeah.
And putting it down how the family wants it written.
Yeah.
And one of the jobs of the care coordinator, if people start speaking jargon, is to say, we're going to back up because we're leaving the family out here. So that's a responsibility. I can see you do
So
that.
we're 2 minutes over, so I want to be respectful of the other sessions, but I'm happy to stick around, as are you, Martha. So if
Yeah,
you all
I think
have other
there's
workshops, so just thank you so much for the conversation. You
really
all are
good.
the experts. Our emails are up here. You know, we'd love to continue a conversation. I got a couple of emails, but if you are interested in seeing the template and having me share it with you, and would be interested in engaging a further conversation, I'll leave the, you know, this picture or this paper up here. Please let us continue this because you all are really the experts, and I get so excited when I'm in front of all you all because we can learn from this process. So thank you so much.
Keep thinking.
Yeah.
Thank you.